sites, etc. But the repression also changed the shape of the market. Most of the cocaine, crack-based cocaine, do the procedure to transform the powder cocaine into base cocaine into their own at home. But since the market is very much tailored by the police, these people tend to buy the stuff as called stones directly on the streets, which make this situation more stressful for them, for everybody, and very encouraging to the drug dealers, which make better cash opportunities for them. So also the repression proves itself have been totally negative, also in the case of cocaine. So we start with Carla Rossi. We have this roundup, hopefully works with the internet connection. Then we wind up with Denis Lahey of this Amsterdam-based organization.
Thank you. It's okay.
Just click here.
Yeah. But I know.
Oh, sorry.
No, I want to stay just a moment on the title, because as Enrico said before, the UNODC asked us to put in the title, general title, drug and not crack, because crack was not linked to the CND. Great. So I got this message. So in the title we put drug, and here I use crack because we are connected and we are dedicate all these sessions to crack. And in Europe, because I can access to EMCDDA data and also to Italian data, so I can also show something strange. Well, crack is a smokable form of cocaine, and one can think that just smokable is nothing different from cocaine. But the effects are quite different, because here you cannot see because the computer is different from mine. But anyway, it's written at the end. You can just see here higher harm to self. You can understand, because it's the computer put the second, what is written over the last table. So what is the consequences of smoking crack on the health is much heavier with respect to cocaine. And usually this has been neglected from official scientific monitoring, because usually you find cocaine / crack all together. So until some years ago, you have just the total subject using cocaine or crack all together. But this is unscientifically, this is what I said. And in particular, this is clear also because the collection from EMCDDA of the estimates of high-risk drug users has just 3 standard tables: one for cannabis, one for cocaine, one for opioid. So crack is not requested, and also polydrug use is not requested. This is essentially because in some sense, the scientific monitoring is also influenced by politicians, because the EMCDDA has, in any country, has a focal point, and the focal point collect and send the data, but also make estimation. And this is in some sense influenced by political issues. But from the scientific part, we have also in a paper of 2004, some very interesting question, is a survey, and show that the crack consumers are quite different from cocaine consumers. So since 2004, this in Europe was known. And recently also the Global Commission on Drug Policy understand this issue and has a report. And the name of the report is Classification of Drug When Science Was Left Behind. And in particular, they say that the policy on drugs should be based on the, say in some sense, the classification with regard to the potential for dependence and other harms. The harms are just harms on self or harms on others. And they say, this is interesting, that some substances are legally available because they are considered beneficial. They are medicine or culturally important as alcohol, while others are seen as destructive and are strictly prohibited. The classification of drug is at the core of the international control drug system. As such, governments must ensure that such a classification is pragmatic and based on science and evidence, makes clear the benefits and harms of drugs, and allows for responsible legal regulatory model to control drugs. This is not usual in Europe also. Quantitative, now I go as they use the results of a scientific award of 2010 on that classify the different substances according to the harm to self and harm to others. We can see that there are indeed two different scientific words on the hazardousness of substances in 2010. One based on the situation in the Netherlands, the other one in United Kingdom, all in 2010. Then the two principal authors of the two work of 2010 decided to work together and to make the same analysis regarding all Europe. And the social and health consequences of substances are also influenced by the different policies. And as in the Netherlands, United Kingdom, and Europe in general, there is some difference between the policies. They use different scales, but the correlation coefficient among the three scales used in the three papers is greater than 0.84. And as the maximum is 1, 0.84 is very high. So essentially, from a scientific point of view, the three work are more or less similar. And this is what regards us today. So the score, the harm score, harm to self and harm to other of crack and cocaine, the ratio in the first work by Van Amsterdam for the work to self is 1.28. That means that anyway, crack is more harm than cocaine. For NAT, so United Kingdom, is 1.89, and the harm to others in 2010 for Van Amsterdam was 1.25, and in for NAT 2.25. When they put all together and consider the entire Europe, then the harm to self remain the harm to self proposed by NAT in 2010, and harm to others goes to the more or less the same value as proposed by Van Amsterdam. So in all the evaluation, so 2010, 2015, crack result more dangerous with respect to heroin. So while cocaine is less dangerous, for instance, than alcohol. So there is really a very different results and different scores for crack and for cocaine. So it's quite important to understand this point and to try to prevent, in particular, the spread of crack use more than cocaine. And now we can see something about the subject who prefer to use crack or cocaine. They are quite different, and this comes also from the cost of the single dose of crack or 1 gram of cocaine, because you see here that crack is is not expensive, while cocaine it is. So from the cost, one can imagine that the market is quite different. And the study published in 2004 has considered many Europe cities and asked, essentially, try to find the typical user of crack and the typical user of cocaine. Is a multi-center study, and you can also find online. And this is quite clear, because you see they were analyzing on the survey subject in treatment, marginalized group and integrated group. And you see clearly here that the marginalized group in Hamburg, but also in Dublin and in Barcelona, and also in Paris and in Rome, use more crack than cocaine, the black here. While integrated group essentially use cocaine. So this also should be considered when you make some prevention intervention, because the population is quite different to contact, to include in the intervention. This is some other result of the paper, but it's quite different because I just say a small thing. The marginalized group has also more poly use, for instance, or crack and heroin. Now I go to data from EMCDDA, presented by Linda Montanari in Italy. And I have this kind of data about crack. So you see that there is a high increase in all this. Wow. In Belgium, in France, in Ireland, in Italy, in Spain, and in Malta, but also in the other countries. But not all send the data of crack separately with respect with cocaine. So sometimes you cannot provide exactly the increase of crack. So these are data of the patient. So these are subject, user, who are assisted by services. So are in Italy in the SEG. Now I use the data, the official data from the Ministry of Health in Italy to see what kind of data represent the EMCDDA data of Italy, because I know from other sources that the person who sent the data from Italy to EMCDDA is not reliable. And this can be shown because here there are the data from the Ministry of Health, the official data, and for cocaine and crack. And the data are reliable since 2014, not before. So here you have data, cannot see exactly from 2000 or 2010, so the first part is not reliable. But the rest also is not reliable, because you see here that, for instance, crack, the behavior of crack is the red one. Red one represents the new user, the new treatment for user in these years. And you see, of course, is increasing. Where the blue one presents new treatment for cocaine. And you see that the behavior is quite different. The same for the person already treated from several years. You have cocaine, that is the black line, and the orange line is cocaine, the new treated. So this is prevalence, this is incidence from a scientific point of view. Now, you can also consider the report, the ratio between these numbers and these numbers, and the ratio between these numbers and these numbers. So the new over the old. And the new cocaine over the new crack, and the new crack over the new cocaine, and the old crack over the old cocaine. And you see that you obtain this kind of behavior. So this means that the crack is increasing much more, because the numerator is less than the denominator. I said correctly the first time, is cocaine over crack, because the crack increase early more, and the cocaine less, so the ratio go down. And if you look at the behavior of the total assisted user in the treatment center, these are the official data from the Ministry of Health, and you see there is this kind of behavior here in correspondence of the COVID period, and also in the other, but there is not that kind of behavior in the data sent to EMCDDA. This is, in what sense, the fact that it's clear that the person in charge of sending the data officially to EMCDDA is not reliable, at least in Italy. And this, well, one can also think that possibly also from other countries there is this problem. And this is very important, and it's important also to check the person in the different focal points that are in charge of collecting and sending the data to Europe, that are at least reliable. And I think this is all what I wanted to say, just numbers.
So we have reached Dr. Thilo Beck, but he could not enter. So I hope everything will be, because it's one of the two frontiers of Switzerland, as I told you before, between German Switzerland and French Switzerland. At least we have one, but now we have hope of the connection with the world. Is a representative of a big the kind of the Tox farm agency with over 140 cooperators. He was all busy all the time. The very beginning was very helpful, but then we almost lost contact. But he knew the bank, so very precise. Thanks to him, and I hope it's working. Okay, and so we have also online. Thank you very much. Denis Lahey, I want to greet you that you're waiting, so you'll be after the other participators. First,
Denis,
no, Thilo Beck.
Thilo Beck, okay, sorry.
He's, yeah, but I wanted to greet him for his presence.
I knew it.
Yes.
Sorry.
And
Come si chiude questo?
Stop sharing su in cima dovrebbe essere. È finito?
fai te forse che...
Se riesco a no, non sta però condividendo.
No, infatti. Ma funziona diverso dai computer nostri questo.
Allora, vediamo se arriva nel Swiffer.
Se no vado a cercare il tecnico. Questo funziona in un altro modo rispetto al mio.
Thilo Beck is yeah.
Io credo di aver chiacchierato troppo.
No, va bene, ma...
Sono andata piano. No, ma rimane sullo schermo un altro.
E dopo Thilo Beck.
Lo facciamo fare? Hello. Hi, Thilo. Good morning, Dr. Beck. Thank you for being here. We had a bit of technical problems. I hope everything is all right. Can you hear us quite well?
Yes, I can hear somehow.
Oh, very well. So since Mr. Cattacin is probably not reachable, I just described in the very beginning, there was a bit divide of, you call it the Restigraben in Switzerland, between French-speaking Switzerland and German-speaking Switzerland. I explained a bit that crack epidemics is a bit different. and introduce also general work. We could start with your presentation of the situation in Switzerland in general, say. Between the French-speaking Switzerland and German-speaking Switzerland, I explained a bit the academics is a little different, and I introduce also general work. We could start with your presentation of the situation in Switzerland in general, say. Between the French-speaking Switzerland and German-speaking Switzerland, I explained a bit the academics is a little different, and I introduce also general work.
Can you see the presentation?
Yes. Share the screen.
Okay. So what I want to walk you through is our experience in Switzerland. And the plan is, after a short introduction of international trends, I want to walk you through the situation in Switzerland and introduce 2 case studies from different cities, just to give you an idea how things work in Switzerland. And I will end with a summary and recommendations. Here we see the situation in the US with increasing, besides the increasing mortality caused by synthetic opioids, increasing mortality rate caused by stimulants. Important to mention is that the most deaths, overdose deaths by stimulants are with combined with synthetic opioids. And that this is for 2 reasons. One is that users combine opioids and stimulants or cocaine. And the other one is that cocaine or stimulants are adulterated with synthetic opioids. This is a very concerning trend. One statement which is very important, I think, is that repression in this area, in this problem field, doesn't work. This is the example from Paris, where the open crack scene has been moved from place to place by the police. And just on the very low end of the presentation, we see the wall of shame, where they closed the open scene off from the neighborhood. So cocaine use in Europe is rising in general. It's a heterogenic trend, though. There are cities with a decreasing trend, cities with a stable trend, and city with a rising trend, but all over it's rising. Important to mention is that crack use is crack users are a small proportion of the all cocaine users in general. It's only about 10%, and with a rather stable trend as far as we can tell from now until 2020 with these numbers here from Spain and the United Kingdom. So there's many more cocaine users than crack users. This is the first data we got from wastewater analysis. It's now possible to analyze for crack residues. You see Amsterdam and Antwerp are quite high in crack residues. And the only time series we've got so far is from Amsterdam, and there hasn't been a rising trend in crack use as far as we can tell from wastewater analysis. This is now the situation in Switzerland. Since 2017, from wastewater analysis, we can tell that there is a stable trend. We have no further increase of cocaine use. You see the cities in Switzerland, that's on the left-hand side, are amongst the 5 or 6 top cities in Europe. what cocaine use concerns, so we are quite high compared to other countries. And this is now the situation in Zurich and Geneva, what the crack use concerns. This is data from the consumption rooms. Left-hand side in Zurich, we have had ongoing crack use since long time, since this is now here data from 2012 until 2022. And you see there is quite a activity, ongoing activity, what crack use concerns. And we have had just in the last 2 years about 30% increase. That's a new trend. Other situation in Geneva. In Geneva, there hasn't been much crack use before 2020, and it has gone up 6 times since then. That's a very strong trend. In both cities, we see users using opioids and benzodiazepines on top. So we see multiple drug use. This is now the example of Zurich, where we have a very good example how consumption rooms, drug consumption rooms are an important part of the whole concept, how people who using crack can be supported. We had 4 facilities, drug consumption rooms spread over the city, catering for about 1,200 people, and increasing inhalative use, crack use. Important to say that social integration is quite well established in Zurich. The social care system works well. We have hardly any homeless people, so they're well cared for. Now, in 2022, one of the 4 drug consumption rooms closed down. That was the most centrally located one, which resulted then in the emergence of an open crack scene in a nearby park. This caused quite some irritation in Zurich. And upon that pressure, there was a provisional drug consumption room on the premises of the previous one, opened after built within 3 months. That was an amazing deed, very fast and quick. And here we see the picture of the consumption room. It's 21 containers. The red area here, that's the ventilation area. That's for the crack users. That's very important infrastructure. Ventilation has to be very strong, so that has to be implemented. This is the supervised entrance for registered users. As I told you, there's about 1,200 people using these facilities. Here we have 19 places for smokers and 9 for intravenous users. So there is more space provided for smokers. There's a lounge area and dormitories. It's important to offer a place to stay and to rest for crack users when they are on the road, like for days without any break. They need to rest somewhere, and they can do that here. There's also provision of food with a kitchen area and a food bar. And very important, a sheltered smoking area where the micro deal can happen. That's something we learned in Switzerland. People using drug consumption rooms, they want to buy their substances on the premises. Otherwise, consumption rooms don't work. Otherwise, people go out to buy their stuff and then use it in the public as well. So when we wanted to keep the scene contained and in a safe environment, micro deal has to be tolerated. Now, let's get to the Geneva outreach project. Geneva is a different situation. Geneva was not prepared for the crack outbreak. In Zurich, we have had this for decades already. And in Geneva, it was imported from France by Paris, by crack dealers who were operating there. The drug consumption room in Geneva didn't have the infrastructure to care for these new crack users. There was too narrow, no ventilation. And so they just had to, they couldn't care for them anymore, and they sent them back on the streets. So the users were exposed to immense stress in open scenes, and we saw a further deterioration of already rather marginalized crack users, and a further propagation of the deal with crack stones. The more stressed the users are, the more prone they are to buy these crack stones, because they can buy them within a minute and smoke them quickly. They don't have to cook their own, so that goes very quickly in a stressed environment. And it sort of increases the frequency of use. And specifically about the population there, the crack users in Geneva, 40% until 50% are homeless, and the large proportion is without health insurance, so in a precarious social situation. The measures taken was now, first of all, the formation of an interdisciplinary outreach team. This has been operating now for 3 months. And further plans are to implement housing first approach and to build another drug consumption room, but that's still in the future. Now I want, last but not least, introduce this interdisciplinary outreach team. This has been operating now for 3 months, and they have had amazing success so far. We guess that there is about 100 severely affected crack users in Geneva, 100 to 150. And so they already met 44 of these individuals in these 3 months and got them into treatment. 44 were medically assessed. 23 of those were referred to opioid agonist treatment. These are users who were in treatment before, dropped out of treatment because of their crack use, and now got reintroduced, which is stabilizing them in an important manner. 22 of these users were without insurance, 21 homeless, and only 18 with 18 the team lost contact. So adherence was quite good for this population. If you look at the needs of these people, housing was the first priority, food supply, so basic needs have to be met first. Then third is stabilization of drug use. So these people, they want to work and reduce their drug use. They're not happy how they are using crack, right? And so they are accessible for therapeutic offers, I think, to how to reduce their drug use if they are stabilized socially. And leisure activities was the first priority. So it's important for the outreach team to cover all these areas and to work in a very flexible way. And that leads me to the summary. It's like a puzzle where all the pieces have to fit if you want to stabilize the problematic crack user community. First of all, we need well-equipped, easily accessible drug consumption rooms with the possibility of drug supply on the premises. We need shelter for these people. And we need an interdisciplinary outreach teams who work closely with other services to address social, psychiatric, and somatic issues. And last but not least, this is a very important point, I think, especially if you think about the future with stimulants being adulterated with synthetic opioids. unsafe supply. We need to offer a safe supply for the for crack users, for stimulant users. There has been a small pilot trial in Zürich in 1994 with base cocaine cigarettes. That was quite successful, but very small, 12 subjects over 10 weeks. And we think it's worthwhile to do treatment trials with cocaine, with the original substance, for high-risk populations, and to see whether they can lead into safer contained environments with this offer. And another pharmacological way to stabilize crack users might be amphetamine prescription. There has been very promising results in quite a few studies with this dexamphetamine in high daily doses up to 250 milligrams. So we think that we should think about cocaine treatment and maybe combined with amphetamine treatments to stabilize the stimulant use patterns of these clients, patients. So that was my overview of the situation in Switzerland, and I thank you for your attention. And maybe combined with amphetamine treatments to stabilize the stimulant use patterns of these clients, patients. So that was my overview of the situation in Switzerland, and I thank you for your attention.
Would you like me to start, Enrico? Yes? Okay. Because I didn't hear you well. It's almost 9 o'clock already, but thank you for having me here, and thank you, Mr. Beck, for saying just almost anything I wanted to say right here. My name is Denis Lahey. I'm the director of the Drug Users Union MDHG from Amsterdam. I'll keep it short. We started in 1977 as a drug users organization, which was in a period in which the drug users in Amsterdam were mainly heroin users, and heroin became a new drug because before the 1970s there wasn't really heroin in the Netherlands. We've seen a shift from heroin to base coke, or crack as it is called in this organization, in this meeting, during the last decades already. That has many reasons why this has changed. Not one of them is the war on drugs. The war on drugs didn't have much effect on it. More of the reasons of this shift is cultural. It has to do with pop culture speaking against heroin. So heroin became a loser's drug, became a bad image. It has to do with a smoking culture rather than an injecting culture of heroin, which made it easier to shift from heroin to base coke, which was also promoted by harm reduction organizations, which were already active a long time ago in Amsterdam. So it has to do with many cultural reasons. I also think it an important reason why the shift took place was what I call the legalization of heroin in the Netherlands. Because by legalization, I mean there are ways that you have a legal production, a legal distribution, and legal consumption. So I'm aiming at the medical supply unit of heroin, which started in the about 15, 20 years ago in the Netherlands. And that had a huge impact. First of all, it had a huge impact on the users. They improved the situation incredibly. Because of there was a supplement of heroin for the heavy users. They finally have had money for food, for housing, for they had rest, not chasing the drug anymore. But it also had a huge impact on the market of heroin. Because when you shift all your heavy users from a market to a legal situation, for dealers it wasn't interesting anymore to have to be selling heroin on the black market. So that had a huge impact on the market itself. So dealers didn't push their heroin anymore. So at this moment, the use of heroin in Amsterdam is very, very low. So that's one thing. So the shiftment of the people who come to the MDHG, which focuses on the street scene, people who have to deal a lot with homelessness, with financial problems, a lot of psychiatrical problems. Most of the users are do smoke base coke or crack, as you say. Enrico wanted to make a statement. I see him waving, but you don't have. You don't have sound, Enrico.
No, thank you.
No, non si può, non si può, non si può.
Okay, shall I continue, Enrico, or I do not understand what you're saying. Can you explain?